demo room, so we're going to get started. First time. Get down here and introduce yourself.
Oh yeah. I hate that. I would sit here and talk about a little bit of football, but since that's a
we'd be here all day.
That's a sore subject with Dave now. But
oh, that was a shot. That was a shot.
All right, so our next speaker for the afternoon, for the next, well, we cut about 15 minutes off of his already, so. No, we'll try to get him all in here for his. Is Dave Maxey. He's one of the RCP lead. CITT. He's one of our lead therapists in our department in Brenner's. But more than just Brenner's, he's in the adults. He helps us a lot in the adult side and showing us his versatility. So,
all right.
Anyway, we're gonna bring Dave in here to talk.
Thank you very much, John.
Yeah, man, come on.
All right. So go ahead and take your stuff there. I got candy.
He's making me participate.
I got candy. We're all going to be involved in this. All you inhalation therapists and respiratory nurses. So I've done respiratory care for 28 years now. Is there anyone here that is not a respiratory care practitioner? So we're all therapists, right? So respiratory therapists. There's several memes out there that show what respiratory therapists do. When they approached me about talking today, originally it was going to be, an hour of memes and respiratory humor and all that stuff, and then we figured out that, we've got to have CEUs. So we're going to look at the clinical practice guidelines, but we're also going to look at some memes, some funny stuff. We're going to do some trivia. So get ready, all right? So this is what your mom thinks you do. Right there, handing the insensitive spirometer out. What nursing thinks you do. Patients think you do. Stop smoking, right? I figured out a long time ago you don't tell your patients to stop smoking. They've all heard that before. Society thinks you're pulling the plug. This is what you think you do. You're sitting there with the chest x-ray, acting like you can see the tube there. And what you actually do, you're usually at the airway end of the code there. So. Being in the field for almost 30 years, I thought it would be fun to start out and talk about some of the equipment that we had back in the day. All right, who remembers this? Yeah, How many people in here have been in the field over 20 years? Show of hands. Lord. All right. So this is the Puritan Bennett MA1 ventilator. This was the ventilator of choice when I was in respiratory school, and that was 88 to 89. It was actually a workhorse in the ventilator. Yep, got the cascade humidifier here. How many people have burned their fingers on the heat element on that burn heater? Yeah. How safe was that? You're undoing, you're unscrewing the heater and exposing it to ambient air. And I've seen therapists cough in it. I've seen stuff fall in the heater. If you watch television shows now and they have a patient on the ventilator, chances are they're going to use one of these because they love this bellows. The bellows goes up and goes down when the patient breathes. And the vent alarm, there's no mistake in that alarm, right? Isn't that it? That's the only thing it can do. And then when you really got fancy, you could make your own IMV circuit. How many people have done that? Made your own IMV circuit? Yeah. All the young people are like, what? Yeah. And this was the control panel for the MA1. Dials and electrodes, and that's the little light that would come on whenever it would alarm. So, I actually think this ventilator is probably still in use in third world countries. Maybe some small community hospitals out there. What about this? Yes. A road thread. The bird marks there. How many people have taken this apart? They used to make us take this apart in respiratory school. How many people have never seen this? So we've all, even the young people. All right. The old IPPB. IPPB probably shouldn't have gone away. I mean, that's basically what the medenim is. It's IPPB. And I thought I'd put this on here. The controls. This sensitivity lever here, it controls the magnet. Yes, sir. Oh, am I too loud? Okay. Is that better? There in the other. Okay. Just talk. And that would actually pull a magnet away from a piece of metal. So the further you would pull that magnet, the harder it would make for the patient to. And the insensitive spirometer. I looked and looked and looked, and I talked to Ron about this. I tried to find the picture of the one that had the clown nose on it. Yeah, you rode that behemoth in the room on 6 wheels and had the little clown nose on top. It actually has the same device for the inspiratory flow. This is an impel-away flow tube, and that would turn and give the machine the information it needed to raise the lights there. You know, now we go in, we give a patient a 50-cent piece of plastic. You know, back in the day, the incentive spirometer was big as millimeter, almost this big. That's actually an incentive spirometer. So he's back out getting that in the bed with the patient. Sir, I'm going to need you to take it. Don't blow. Don't blow. Breathe in. Breathe in. Right. And if you were Neds for CHF, you need to be Batman slapped, right? That'll be good. So what we're going to look at today is the current AARC clinical practice guidelines. There are 5 different areas, and guys, these are still listed on the AARC website, but I will tell you that a couple of these are from the early 2000s. Yes. So we have inhaled nitric oxide for neonates, care of the ventilator circuit, weaning and DC vent support, and basically airway clearance therapy for non-medicine and medicine. Okay, and I actually jotted down the years that these were posted on the website. Airway clearance is 2015. Non-airway clearance is 2013, nitric oxide is 2010, the vent circuit and VAP is from 03, and the weaning and DC vent support is from 02. But there's still some important data to be culled from them, even though they're older guidelines. How many people give NEBs to people who just got extubated? Post-ventilator one? Nobody's giving that? Y'all are a tough crowd. So we're going to do a little Q&A here, a little trivia. I got some candy to give away. Elizabeth has graciously offered to be first. She's going to go. Come on, Elizabeth. You can do it. You got a 50% chance to get it right. It's true or false? True or false? Can't be back there. All right. Don't hurt your back. Don't hurt yourself. All right. Elizabeth, stand. Come on. Hands up. Come on. Come on. Introduce yourself. Introduce yourself.
I get the answer right.
This is Mount Pittsburgh.
Elizabeth, what's your favorite ventilator? Okay, very good. Okay, so tell me this, Elizabeth. True or false? True or false? Is it recommended that INO is it true? Is it recommended that INO should not be used routinely in newborns with CDH? Is that true or false? Take a guess. Got 50% chance? True or false? You're right! Well done. Take your choice of incredible prizes there. What's your pick? What's your deal?
Sweet tarts.
All right, good choice. Good choice. All right, well done. So I thought this was on point for the season with Michael Myers here. Originally, I thought this was a screen grab from the original film in 1978, but if you look here, there's a late model Ford Explorer. So, evidently, someone's taking pictures. All right, next question. Who wants to do this?
Come on,
Guys, we got candy. Come on.
Spread it out.
Yes.
Spread it out. Don't make me pick.
Don't make me.
Missy Latessa looks like she's ready. All right, well, if there's no volunteers, we'll just roll. All right? Well, do you want to raise your hand to do it? 50% chance of candy. We have a hand over here, gentlemen. Oh, Leanne. Leanne. Leanne.
All right, Leanne's gonna do it.
All right.
There we go.
Maximum duration of time that circuits can be used safely is unknown. Is that true or false?
It's false, but it's starting to change.
Say false.
Maybe I read the question.
Give her the candy. Give her the candy anyway. Good job, Leanne. We're going to look at all these after we do the questions. I'm kind of throwing y'all a curveball. I can't remember her name. What was her? Sweet. All right. Who wants to take a stab at suction catheters? Anyone? Raise your hand. I'm hearing the right answer. Who's answering?
It's false.
Raise your hand. Get candy. I'm hearing false.
Okay, we're hearing 3 or falses.
All right. It's false. All right. Very good. Very good. You know they're making another Mike Myers. They're making another Austin Powers. He signed up for you. All right. Another question.
3 more lucky people.
Okay. Take them down here.
Look at that.
True.
She's saying true.
Yeah.
Saying true. Okay. Flow suction catheters should be changed daily for infection control purposes.
The manufacturer's recommendation is that it is changed daily.
Oh, I'm sorry. Just give her candy.
That's okay.
Give her candy. If you don't choose the Sour Patch Kids, you're crazy.
Oh,
Oh, Sour Patch Kids. Got no other therapists in here. Don't you want to take a yonker to that kid and just go down? All right. Airway clearance therapy is not recommended for routine use in patients with COPD. Is that true or false? Raise your hand to get candy. Sarah, raise your hand. What do you say, Sarah? True or false? False. Oh, it's true. It's true. Not recommended for routine use in patients with COPD. Grumpy cat? Drunk about 90 pounds. Get it? Okay. But I think there's only 2 more questions. Incentive spirometry is not recommended for routine prophylactic use in post-op patients. Not recommended for routine prophylactic use in post-op patients. I know. And see, that's one of the things is these clinical practice guidelines, we take orders from physicians, right? So we have to do what the physicians say. But the answer to this is yeah. They actually, well, and we'll look at this, but they actually say getting the patient up, moving them around and getting them to cough does more good than giving them an incentive spirometer. But I mean, come on, show me a surgeon that doesn't order IS on the patient after surgery. Another little meme. You ever feel that way? All the time. Routine use of bronchodilators to aid in secretion clearance. Secretion clearance is not recommended. Would that be true or false?
That's right.
We got one more box of candy. I think there's 2 questions. True. She's saying true. Boom! Give that woman some, what is it, lemon heads?
Lemon heads.
Shoot lemon heads. Well done.
Who was that? Who was it?
Sure.
There it is.
Kevin, don't hurt your back.
No, I know, man.
All right. Before you yell at a therapist, you, in the future you may need to yell for the therapist. So, all right, last question here. There is no high-level evidence related to the use of bronchodilators, mucolytics, mucokinetics, and novel therapy to promote airway clearance. Is that true or false? True? I'm hearing true. It's true. It's true. I know. So let's talk about it. I know this is wordy. Don't let your eyes glass over. So we'll go through a few of these. The study with nitric was probably, I mean, it was gargantuan. So I only picked out 5 points that I thought were telling and made me scratch my head. So it is recommended that INO should not be used routinely in newborns with congenital diaphragmatic hernia. Anyone know why that is? Anyone at all? They don't have lungs. They don't have lungs. Chances are those kids are not going to have the lungs to receive the nitric oxide. And I will say that we've moved away from using nitric oxide to using Flow-N because it's so much cheaper. But usually your kids with CDH, and there are different varying, there's varying degrees of CDHs. But usually when there's a herniation and the contents of the gut come in to the chest, it inhibits lung development. So that's why basically they say that it should not be used routinely. But if you do have a CDH that has some lungs, I can see using it. Suggested that INO therapy should not be used routinely in newborns with cardiac anomalies, depending on right to left shunts. A lot of these kids are dependent on the mixing of the blood, so they're usually good until you can do a surgical repair. If you do give those kids nitric, you're going to dilate the pulmonary vascular bed, and it's going to rot from the systemic, and you can see where that would lead. Recommended that a response to a short trial should be judged by an improvement in PaO2 or oxygenation. Newborns with parenchymal lung disease recommended that optimal alveolar recruitment be established. That makes sense because you want to dilate and you want to get the lungs open so they can receive the nitric. And then the last one is about discontinuing the nitric. A lot of these kids are so dependent on it. I've actually seen us get to 1 part per million and then wean by 0.1 until you get to 0 because they will crash on you quickly. Next is care of the ventilator circuit and its relation to VAP. Now this is one of the clinical guidelines that came out in 2003. And y'all are going to have to help me here because I think that they changed the wordage. Is it not VAE now? It's a ventilator associated event. I see Jim Pittman standing up there. So typically VAP, they would call VAP, you had to be on the ventilator for 48 hours or greater and develop a pneumonia that wasn't there before. But now I think they've gone back and they've established some criteria.
Yeah, in fact, VAE is divided into 3 categories. You have ventilator-associated condition, infection-related.
So ventilator-associated condition, ventilator-associated event,
possible VAP.
And possible VAP.
The reason why they changed this whole way that they looked at it was because it required radiographic evidence and it's very subjective. So what they did was went to where they required you get a baseline of the patient over a 4-day period after going on the vent. And then what happens is if the patient starts to deteriorate, they look at your FiO2 changes in that if you have to increase some of those. It's not to say that you can't increase, but if you stay at that limit for a certain amount of time, then that's when they decide it as their bid.
All right. Need to get Jim up here. Should have given him the microphone. So I don't know if you guys can hear that, but they have changed the way that these are classified. So this is going to be, they continue to look at this about passive humidification versus active humidification. You know, they say, ooh, passive humidification is great, but then resistance, dead space volume, if your patient coughs up a loogie into the HME, those kind of preclude you using passive as opposed to active. So remember earlier when I was talking about the MA1 and how you had to unscrew the humidifier to fill that? Obviously now we have closed chambers, we have bags that will auto feed the humidifier. So that's been huge in fighting that. And then there's the question that we had about the closed suction catheters. As part of VAP strategy, they do not need to be changed daily for infection control purposes, and the maximum duration of time that closed suction catheters can be used safely is unknown. So they just don't know. You know, we basically change ours when visibly soiled or when, you know, when we have a hole in them or something like that. So the science points to they don't know how often they should be changed. Anybody see anything wrong here? She just got a horrible laceration on her nose. It's not menstruation. That was actually on the Hallmark Channel. And you can see they made it, yeah, Hallmark Channel. It's almost Christmas season. Y'all be watching Hallmark before too long. Yeah, can you imagine the peak pressure you get through that yonder? They would be out of sight. I mean, where's the consultant? Was there no one there to say, that's not for that, that's not what you use? And what holder is that? Is that a holder from a, what is that? Is that from a tray? Is that a tray tie? Or I don't know. Maybe that movie will be on this winter. So this is the guideline for weaning and discontinuing ventilatory support. This is very wordy. This is it's a lot of common sense type things, like if a patient fails, you need to find out why they failed. I believe that's the first one. Inpatients requiring mechanical ventilation for greater than 24 hours. A search for the causes contributing to the ventilator dependence should be undertaken. The second one, if they have respiratory failure, they should undergo a formal assessment. Duh. And that will include evidence for reversal. You always look for reversal, adequate oxygenation, hemodynamic stability, and the capability to initiate an inspiratory effort. And then there's 3 through 6 here. Formal discontinuation assessments, obviously, the removal of the artificial airway from a patient who has successfully been discontinued from ventilatory support should be based on the assessments of airway patency and the ability of the patient to protect the airway. Wow. Duh. Okay. And if they fail an SBT, you need to figure out why. And then if they do fail and need to go back on the ventilator, they should receive a stable, non-fatiguing, comfortable form of ventilatory support. Right? Any Grey's Anatomy fans? Yeah. Okay. We all know why he peached out. 5 centimeters at the lip, right? And it looks like he's chewing on his vital cord. How long ago did he die on the show? I don't watch it.
Several seasons.
Several seasons. And that show's still on the air?
Yes, it is. It's on tonight.
Really?
Yes.
Yeah. Well, they need a consultant as well. So now we get into the airway clearance therapies. Basically, there's medicine airway clearance and not medicine airway clearance. So when I read these clinical guidelines, you have to realize that they're talking about airway clearance. They're not talking about for wheezing. They're not talking about for bronchospasm. They're talking about trying to clear secretions. And these were one of the questions that we had earlier that was we were kind of taken aback by. But chest PT not recommended for the routine treatment of uncomplicated pneumonia, and airway clearance therapy is not recommended for routine use in patients with COPD. But it may be considered in patients with COPD with symptomatic secretion retention guided by patient preference, toleration, and effectiveness of therapy. Laura is one of our navigators. You still have the mic? Sure. Anyway, I'll just ask her. What do y'all do for your patients, your COPD patients? Do you do chest PT with them?
We get a lot of aerobics.
Aerobic.
They can use it independently.
Okay.
And sometimes we'll use rap therapy.
So it's basically COPD patients that have a lot of secretions that they need. Okay. That's good. Who's worked with the aerobic? It's fantastic. Some people call it the aerobic. But you can actually take it apart and clean it.
Dishwasher safe.
Yeah, dishwasher safe. Man, those patients used to come in when we used the acapella, and there'd be all kinds of junk in it. Airway clearance therapy not recommended if the patient is able to mobilize secretions with cough, obviously, but instruction and effective cough technique may be useful. And this one really threw me, and this is what we talked about earlier, about the post-op adult and pediatric patients. Incentive spirometry is not recommended for routine prophylactic use in post-op patients. Early mobility and ambulation is recommended to reduce post-operative complications and promote airway clearance. So basically what they're saying is that we can go in the room and we can give the patient an incentive, and I call it insensitive, give them the incentive spirometer, but getting them up, getting them to move around, take deep breaths and cough is going to do all the good in the world. I don't know if it's necessarily saying that you shouldn't do it, but it looks to me like it's saying that you need to get the patients up and get them mobile. So for adult and pediatric patients with neuromuscular disease, respiratory muscle weakness, or impaired cough, they basically say that the cough assist technique in those patients with neuromuscular disease, especially if their peak flows are greater than 270, because you know that patient's going to be able to generate the expiratory flow to clear those secretions. They say that CPT, positive expiratory pressure, intrapulmonary percussive ventilation. Have y'all ever done that? That came out right after, right before the Medinet came out. When I was at Vanderbilt, we did IPV. Intrapulmonary vibration, it was a lot like the IPPB treatment, you know, the Bird Mark 7, where you would give the patient a positive pressure breath, but those treatments are so dependent on patient effort. They have, like with the IPPB, the patient has to have a good mouth seal to get the breath to terminate. And that's what IPV was. It was a great treatment, but it was so fatiguing to the patient, they couldn't keep a good seal on the mouthpiece. So I didn't know if anyone else had ever seen it. High frequency chest wall compression cannot be recommended due to insufficient evidence. I guess that's talking about the vest machine. More non-pharmacologic airway clearance therapies, the lack of available high-level evidence related to ACT should prompt the design and completion of proper design studies to determine the appropriate role for these therapies. So basically that means get with the doctor, get with the nurse, get with the pulmonologist, develop a plan for these patients to help. All right. Any questions on that? No? All right. I'm just going to leave that right there. Okay, so the next clinical guideline is about medicine. It's about medicine therapy. And guys, this thing was pages long, and basically I took the summary of what the team came up with. And I wanted to include who was on the panel to let you know that these are therapists. These are people like you and I that have done this for a living. This isn't a bunch of doctors, it's not a bunch of nurse practitioners. And actually Bruce Rubin worked at Bremer for a while. I'm not how he left for Virginia a few years ago, but he was on the committee. So you've got 1, 2, 3, 4, 5 therapists and a doctor. And basically, I'm not going to read this to you because it's very wordy. But they did studies, and basically, they're saying don't give Dornase alpha to anyone who doesn't have CF. Has anyone ever done that? Because I've actually given it to patients with secretions before that, you know, that have consolidation that you just can't get popped open. The thing about it is when you use an expensive drug like Dornase alpha, if they are atelectatic, that drug is only going to go to the areas that are already open, right? So you need positive pressure. Blah, 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 blah. They're saying that basically they show no clinical improvement for airway clearance. And that's basically what this slide says. The routine use of aerosolized Dornase alpha to improve airway clearance is not recommended. Aerosolized agents to change mucus biophysical properties or promote airway clearance are not recommended for adult or pediatric patients with neuromuscular disease, respiratory muscle weakness, or impaired cough. Mucolytics are not recommended to treat atelectasis in post-op patients, whether adult or pediatric, and the routine administration of bronchodilators to post-op patients is not recommended. There is no high-level evidence related to the use of bronchodilators, mucolytics, mucokinetics, and novel therapy. I'm not sure what they meant about that, to promote airway clearance in these populations. So that's very wordy, but basically they're saying for airway clearance, for the clearing of secretions, that they don't recommend any aerosolized medications. I got to tell you that when I first read these, I thought, wow, the AARC doesn't want us to do anything. So, but it's all about the evidence. It's all about the studies that they've done, and a lot of it is subjective, kind of like Jim was talking about with the VAE or the VAP. You know, a lot of that came down to looking at chest films, and chest films can be very objective. One person can see one thing and the other won't see it. So there you go. Gonna close with this. You don't know you can do that?
Oh.
Yeah, I know. You can actually innovate with an albuterol net. I know. What is Dr. G?
Garrett or something. I forgot. I used to watch her all the time. Yes, she is.
Well, they need a consultant on set as well, because I'm telling you, that's crazy. How did they tape it? They got the tape around it. All right, guys. Do y'all have any questions about anything? Anybody want to volunteer? Is there anyone in here outside of the Wakehouse family? How often do you guys change your vent circuits? When needed. Yeah.
Doing ours now every 30 days.
Every 30 days?
The vent circuit, yes. 30 days.
That's a long time to wait.
We're a LTAC.
Okay, that's what we're.
Oh, you're an LTAC. Okay, I'm thinking 30 days. Wow.
Does the circuit get dirty?
Yeah, but we change them if we see
Oh,
it's
okay.
dirty too.
Oh,
But,
okay.
you know, that's what they're making us do it in the first of every month.
So 30 days in an LTAC.
Yeah, or if it's dirty, it's
Anybody else? Have anything? Who?
Have women in the NICU change vent circuits every week and Ballards every day.
So you have a set schedule of when you change those out.
Great.
Yes, sir.
Please share the comments because we couldn't hear them back there.
Oh, I'm sorry. Where's the mic? You need to pass the mic around.
Oh, God.
Well, get it up here, dummy. Just stand right there.
Just share the comments that were.
Okay, could you repeat that? Because the people in the other room can't hear. Pass the mic over here. And you can go first if you want to. Just the mic's right there. Just tell us what you do in the LTAC.
We started changing the circuit every 30 days in the LTAC, but if it's dirty, we do it.
Do it as
See
needed.
it as needed, yes,
Okay.
PRN.
All right. And what hospital are you at?
Women's Hospital. And the NICU, we change vent circuits weekly. We put stickers on there with the date. So we do that, and ballots are changed every day.
Okay. All right. Thanks for sharing that. What about, so you said the Ballards you do, you do daily Ballards.
Yes.
You want to do some Ballards?
We are this month,
Yeah.
yes.
Is that what they recommend? Ballard recommends every day? Really? Anybody else with changing out vent circuits or Ballards or anything you want to share about airway clearance therapy? Do you typically do vests with patients? How many facilities out there do you use the vest? Where do you work? What's your facility? Where do you work? Oh, Wilkes, use the vest. Now, do you use that on adult and pediatric? Okay.
Just curious. For the days changing the ventilator circuits? Every 30 days?
Well, she works for an LTAC. Yeah, so these are that's a long
Still,
term.
how do you come up with, why do you justify 30 days, not every 10 days?
Come up
Are
with.
they doing studies or
Talk to the mic, yes, talk to the mic. All anyone see anything jump out at them on the clinical practice guidelines that made you go, wow, that's not the way we do it? Because I gotta tell you, the one about the post-op patient in the IS, I was like, that's, I've never, you show me a surgeon and they're gonna give the patient an IS.
Well, when you compare it to getting up and
Yeah.
mobilizing, I mean, you
Right.
see it there.
Yeah.
But just to say that.
Right, and you know, then you have to get the patient up. If you're not going to give the incentive spirometer, you better be getting, you better be getting the patient up out of bed and encouraging them to come. Absolutely. Anything else? Any more input? Any more questions? All right, guys. Appreciate you. We've got about 12 minutes before the next lecture. All right. Thanks, guys.
All right, thank you. I'm sure Shane will use that. Everybody wants to be quiet. Nobody wants to want candy.
Oh, thank you. You shouldn't have.
We really shouldn't have. Jennifer insisted.
You really shouldn't have after
Where's he at here?
the click.
I don't see it. This is not on here. So if you need to take out a quick break, you got like 10 minutes. Do you see his on here? Hey. Nope.
What's the name of his talk?
Shane Martin, chest wall injuries and pulmonary contusions and respiratory implications. There he is right there.
Oh, what's happening? Right on time.
Hey Shane, how are you? How are you? Good. I'm sure you had the encrypted.
I did.
Everybody's coming here today trying to stick. There you go. They were all encrypted, so they were having to email it to me.
Really? Let's see. Is that it? That's it. Let's do this. Yes. Are we still at 2 or are we running ahead or something? What's your is your plan to give it?
You got about 10 minutes.
We gotta give a break
Yep.
until we'll start on running right on time.
Right on. We had a little technical difficulty on the last one, but we got to go.
Kevin. Hey, Doc.
How are you? I'm
Good,
good, thanks.
good. Kevin, do a test so we can make sure the sound is right. It might have been Dave, but do a
Could have
test
been
so
me.
we can hear it.
Just over there?
No, do it from here so we can make sure we
Are
hear
you
it
gonna?
over
Which
there.
one are you gonna? You're gonna use this?
Would you rather use the lapel trunk or?
Shane.
Yeah, I'll use that. I'll move around a little bit then. Keep me away.
I've got it on. Give us a check mic when you get your thing.
Okay. I'm gonna put it on the desktop here, I think. Yeah, I can get my drive out.
Trying to get the sound right. No, it's smoking. He really was. He was not crystal clear. Now you're right. We want to test it.
Okay. It's gonna work.
In 30 seconds, say testing 1, 2, 3 for me. I'll be in another room.
Okay. Oh, there's another.
What's that?
There's another room with people, huh?
Well, yeah, it was full. I mean, so we just and set it up through YouTube and streamed it.
Sure. Okay, cool. Good idea. Was it just next door? Is he there yet? Now. Sound check. Testing, testing. It work? No?
Make sure this one's loud. I can hear you in there, but it's feedback.
Well, it was loud when I first said it.
Oh,
I
well,
had it here. It was real
It's
loud here.
really loud. See, this one's still on. Now see if you can hear him. They want to have an IT person in there, but they never want to send nobody down. They just want to go, just push this button and that button, and then they
Make
make
it
it
like makes sense, right?
Mm-hmm.
Testing now. Can you hear me? Testing, testing.
He just did.
I'll do it. I'll do it again. Testing. That one's working. That's fine. I can do that.
Here, just turn it off, or just turn that one off. Now we'll see.
Can you hear that? Testing.
Now can you hear that over there?
Can you hear that over there? That should be both working. I think this might have been quiet. I think this was working. I just had it too low. I'm trying to get it because when I did this, it was way too loud.
This works. I don't know what they're.
Can you hear it, Ron?
difference whether you have one on or not. As long as it's not. Oh, he says yes.
Try it again, one more time.
One more time, try it. He's gonna be out of breath.
How about now, Ron? Can you hear that? Sound check. We'll go with this then. That's good. That'll work.
Just
Then I might lean over too much.
Yeah, this is you're the. Yeah. And one more after you, and then it's here all day tomorrow until 4 o'clock, 3 o'clock. What are you trying to fix now, then? Close enough. You ready to get started here? All right, we're going to get started here again. I want to introduce the next speaker here. This is Dr. Shane Martin. He's one of ours at Baptist Hospital who's been around for a while. Actually started there as a resident and did his surgery and trauma fellowship there and has stayed on with us, which we're all glad of. And he's also the associate director of all surgery or just critical care? Of critical care there. So he's going to be talking on chest wall injuries and pulmonary contusions. And so, Dr. Martin.
Thank you. Thank you. I think we got the sound stuff checked out on this. Well, this is great. I think one more today, and then you have a full day tomorrow. What a fantastic conference this is. I've been fortunate enough to come down here and speak a couple of times, and it's really fantastic. The only question I have is actually who's doing respiratory therapy right now at our place? Because I think I see everybody that I know. So okay, but so I noticed that on the agenda there are a number of different topics. So we're a little more clinical in this one. and a little bit more related to a unique patient population. But I'm going to talk to you today about chest wall injuries and pulmonary contusion. The two really go side by side with one another. And we deal with them a lot. They're a major issue. Those that spend any time with the trauma service, both in the trauma ICU and on the trauma floor, know that we deal with rib fractures and other chest wall injuries all the time, as well as then the challenges that come with pulmonary contusion. So today I'm going to talk to you about, begin just by setting the stage with some information on the anatomy and physiology of the chest wall and really the chest in general. We'll then talk about some of these different pathophysiologic states, some of these injuries that I'm talking about, and what are the implications of those injuries. And then lead right into what are some of the things that we do about those injuries, and what are some of the mainstays of treatment that we always need to keep in mind when we're managing these patients, some of which can be quite complex. So just to start off, when we think about the chest wall, really we're talking about the bony thoracic cage, which consists really of 12 ribs on both sides, a sternum in the middle, and then the vertebral column around the back. Now those ribs just don't sit there. They've got musculature both in the intercostal spaces as well as the diaphragm, which are all critical to the respiratory function of the human being. So here you can see looking for anteriorly, you see the ribs that I described laterally. You see the sternum, and you see then also the costal cartilage, which is important because one of the things about the chest is it's not just a rigid bony structure. It's actually a very dynamic organ. It's constantly moving. So while the bones themselves bend very little, the actual the chest as a whole has quite a bit of movement, and where the bones articulate with one another, there really are joints there, a lot of which are, some of which are actual joints and some of which are just costal cartilage that has a give to it. And so that ends up being important when we think about some of these injuries and some of the ways in which we address the needs that those patients have. Just another photo looking a little bit laterally, and you can see then around the back where the spine is. We forget about that part of it, but a lot of our problems end up being around the back. But the chest, as it moves, actually changes shape. As we take a breath, the chest changes shape, and what allows it to do that are those joints that I was describing toward the back, and then the give of the costal cartilage around the front. Within the chest, of course, you've got the lungs themselves, left lung with 2 lobes, right lung with 3 lobes. That comes into play a little bit when we're talking about pulmonary contusions, and we'll talk about that a little later. Of course, there's the airway side of things. Within each of the lungs, we have the larger airways as the air toward the superior portion. They divide then sequentially down to the segmental and subsegmental, and further down to ultimately the alveolar air sacs. And that's where we'll talk a little bit about some of the issues with pulmonary contusion at that level. So there are a number of other problems that can occur at the airway level, both at the upper airway and then the lower airway. We're not going to really talk much about that. We'll confine this discussion to the chest wall, but we will talk about pulmonary contusion. So when we think about that, those tiny alveolar air spaces are going to be really a critical aspect of what we talk about. So the physiology of the chest is, it differs to some degree depending on whether we're talking about patients or whether we're talking about people like ourselves right now that are breathing without any levels of support compared to those that actually have support. What I mean by that is the pressure within the chest between the lungs and the chest wall is actually a negative pressure. And the result of that then is whenever we increase our thoracic volume, both with the use of our accessory muscles, with the use of our diaphragm, so we increase the volume within the chest. What we actually do is we expand the lungs, and that activity is performed by actually a negative pressure. Most of you live in the world of positive pressure, where we're providing that airflow through something that we're providing externally in a way that we're forcing air in, whereas right now, when we're breathing, we're actually just increasing our thoracic volume, and that is then expanding our lungs because of that negative pressure. Another photo here. You can see some of the. You can see there the differences between the atmospheric pressures, and we actually then, when we increase that volume, we actually pull the lung to a larger size, and it draws air in to our to the alveolar spaces. So, and that's important because there are some diseases, and again, not something that that are directly related to this, are things like pneumothorax, where when that space, then that negative pressure is obliterated, we have trouble then expanding the lung. Okay. Again, not something we'll specifically talk about today, but it does come into play when we're talking about people that have rib fractures that are not on positive pressure. They have significant then limitations in their ability to expand their intrathoracic volume and therefore expand the lungs. And that'll get to a lot of the issues that we then end up having with rib fractures. I'm not going to go into this in too much detail, but you can't. It's hard to say anything about pulmonary physiology without at least showing the various different pulmonary volumes and capacities. These come into play obviously when you get a little bit more in depth into the ventilatory side of things. Again, I'd be remiss if I didn't include that. So, knowing then a little bit about then the anatomy and physiology of the chest, we'll now start to talk a little bit about the pathophysiology. And there's really two very important points of pathophysiology that are important. And these are really general types of things that many disease processes can lead to, but they're important to understand because then it helps to understand what actually is going on in some of those other disease processes. So when you think about the pathophysiology of the respiratory system, there really are two big things that we worry about. One of them is shunt, and the other is dead space. Both of these are considered to be ventilation perfusion mismatch. Okay, the concept being that there is some, in normal state, we have the right amount of blood perfusing through the pulmonary vasculature to line up with the amount of air we have going in and out of the lungs, the airways, and then the alveoli, to have the right amount of exchange of oxygen and carbon dioxide. Okay, so in the normal state, the body does a good job of regulating that blood flow through the pulmonary vasculature and that air coming in through the in and out of the lungs. Well, when we have various diseases, that impacts it. And so there's two ways in which it impacts it, and they're really converse of one another. In the state of shunt, there is perfusion of lung units, but there's no ventilation. So there's various different states. You can probably think of several off the top of your head where we have trouble with getting air into those sacs, and we're going to talk about that because that's really pulmonary contusion is a state of shunt. Okay, we have trouble getting air into those alveolar spaces, but we have perfusion through them. So at the end of all of it, then the outcome's the same, which is we do not have exchange of oxygen and carbon dioxide. Essentially, then deoxygenated blood enters the systemic circulation, and then when you calculate the number on that, your ventilation to perfusion ratio, your VQ, many of you, if you have, we don't do a lot of speaking about VQ, but at minimum we hear about, sometimes still, about VQ scans, right, where we're looking at the relationship between that ventilation and perfusion. But in the state of shunt, your VQ, your ventilation to perfusion ratio is 0, okay? Because, again, a very minute number in the numerator there and a larger number in the denominator then approaches 0. The converse of that is dead space. Okay, and there are actually, as all of you know, that dead space can actually be, some amount of that can be physiologic just by the fact that we have air moving in and out of a fairly long system. If you took all the tubes and lined them all up, it's a very long, and it'd be challenging to get air fully in and fully out within each breath. So we actually have some amount of dead space physiologically, but we also, this occurs in disease states as well. And in dead space, you have ventilation of lung units, but no perfusion. Okay, so air is moving in and out, but then there's no perfusion. So gas enters and leaves the lung units that don't contain blood. Okay, in this case, what's thought of is that this is wasted ventilation, and in that, and as I discussed with the VQ ratio, in that case, VQ is infinite because the ventilation side of it is very high, and the denominator there, the perfusion side, is very low. So when again, if you take any of the problems that you take care of on a regular basis, you would be able to probably put them into one of these categories as to whether they're involved with shunt or whether they're involved with a dead space pathophysiologic state. So just looking at this in a figurative form, on the left side, you can see shunt. So you have alveoli that are poorly ventilated, as described up as figured up here, and you have blood coming in, but then blood leaving that is poorly oxygenated because again, does not have the usual contact with the air within the alveolar space. And that is in opposition to the physiologic dead space, or actually dead space, where you have ventilation, but you don't have blood flow, okay, for various different reasons. Okay. So moving in, so now that we have this basic construct of what are really some of the most basic issues that occur with the respiratory system. Now we'll talk a little bit more about some of the pathophysiology of various different injuries. So rib fractures are very, very common. We take care of them constantly. Described here that more than 50% of non-penetrating trauma have rib fractures. As our populations age, what we have found over the last decade is what used to be the greatest mechanism of injury in trauma patients was motor vehicle crashes is now falls. Okay, there's a few reasons for that on both sides. One is the vehicles have become safer, and there's a lot of safety systems that prevent many injuries from occurring, and people walk away and aren't admitted to trauma centers that would have historically. But the other is that we have an aging population. The aging population tends to fall. And one of the common injuries that occurs with falls are rib fractures. The challenge there is not only is it becoming more and more common, but we're talking about now people that are more advanced in age and have less physiologic reserve and less of an ability then to get better when they have rib fractures. So what we're seeing is a really challenging time right now with more and more rib fractures and more challenging patients that have them. Some associated injuries that we can see would be pneumothorax and some amount often of hemothorax where there's some bleeding into the pleural space. That can be challenging. There can be needs to address that as well that add another element of challenge to the situation. So the ribs actually, I hear that they break at point of impact or posterior angle. They'll break in lots of different ways, and one of the interesting things that we do here at Wake is we actually have a crash reconstruction center. So we have a contract with the Department of Transportation where we do analyses of car crashes, and what we look at a lot are we end up looking at rib fractures a lot. And what's interesting there is to see, depending on the type of crash, we see different types of patterns of rib fractures, okay? So that gets to that breaking at the point of impact. There are various different sort of features about each of the ribs individually. If you look at the first few ribs at the top, they're relatively protected. They're smaller in their diameter, they're a little thicker, and they're harder to break, and so they're oftentimes associated with severe intrathoracic injury, or at least evident that they provide evidence of high energy. Okay, the ribs below that, 9 through 12, are quite a bit more mobile, and even in the lower area, just because the thoracic cage covers the upper part of the abdomen, can be associated with intra-abdominal injuries. So along those lines, if you have rib fractures on the right side lower, you have a 3 times greater chance of having a liver injury, and on the left side, 4 times the likelihood of having a splenic injury. One of the things that we've also seen is that as we age, our bones become less elastic, and so we can see almost a linear relationship between broken ribs, the likelihood of breaking your ribs and your age, as we age, we have a greater likelihood with less energy of breaking our ribs. The interesting thing also is that pulmonary contusions, which again we're going to talk about in a moment, the bruising of the ribs inside, bruising of the lungs inside of the ribs, tends to be greater in young people because the ribs give, they contude the lung, but don't break, than they are in older people. So you almost see these two crossing lines as we age, with increased rates of rib fractures for comparable amounts of energy and decreasing rates of pulmonary contusion. With rib fractures, and I'll actually have a photo in here that you can see. So we worry then about the chest wall itself. We also worry then about the bruising of lungs beneath it, the contusion of the lung. But the actual rib fractures can tear through the pleura and cause lacerations to the underlying parenchyma of the adjacent lung. You can also see that in the abdominal structures as you get toward the lower side. We also know, as I alluded to earlier, that the elderly patients have a substantially greater risk of death with multiple rib fractures. In fact, you can quantify that as you increase rib fractures, something like almost a 7% increase in mortality per rib fracture as we get into our later years. So clearly a major problem from that standpoint. So just a figure here of some what we would consider to be anterior lateral rib fractures. And again, they can occur in lots of different places. So depending on whether it's a anterior to posterior energy transmission, lateral energy transmission, or some variation of that, maybe loading even of the upper thoracic cage, you can have various different patterns of fractures. In fact, what we'll see with seatbelts as an example, you can literally track the seatbelt across the thoracic cage and see the rib fractures that are right beneath the seatbelt, and you can even tell where somebody was sitting in the car based on the direction at which their rib fractures are. So they tend to follow, again, that point of impact significantly, particularly if they're if you have something that you can identify as being that contact point. Maybe a little tough to see here, but this is a plain X-ray of some rib fractures on the left side. We don't do a lot of at least at the trauma center level, we don't use the chest X-rays a lot for identifying rib fractures. We end up usually seeing them on three-dimensional imaging, which I'll show you in just a moment. And there is one important point to that we often quantify our rib fractures, and there is some prognostic value in that. But I would also keep in mind that the chest that hurts, whether you have broken ribs or not, is a problem. Because if you think about what the actual disease, what the actual problem is going, and that we'll discuss, is that of adequate pulmonary expansion, airway clearance, etc. Pain, whether you have one rib fracture or 6 rib fractures, or whether you have none and you have some intercostal injury or you have contusion to the bone, can still be just as significant a problem. And so I try to encourage everyone to not get too caught up with the actual numbers of the ribs. Now, we do use it to prognosticate. So we know that people that have greater numbers of rib fractures have greater likelihood of having poor outcomes. So that may guide us toward a therapy, but it definitely doesn't make us say, no, that person doesn't need something because we can't see anything but a couple of ribs. We end up having to then address those rib fractures just as aggressively as we would somebody that has a higher number of them documented. So this is actually a CT of the chest with a three-dimensional reconstruction, and I like this photo because it definitely provides an opportunity to see three-dimensionally several rib fractures. You can see some arrows up here on the upper anterior, and so an anterior lateral rib fractures, but you also then get a chance to see a number of posterior rib fractures down the back. Okay, we're going to talk about this phenomenon right here. These two ribs have fractures in 2 places. They're 2 contiguous ribs with fractures in 2 places, which is what we would call a flail chest. And we'll talk about that in a moment because it is a very advanced form of rib fractures, and one that we have a great deal of concern about, not necessarily because of the ribs, but because of the associated injuries. But this is this photo or this reconstruction provides a nice opportunity to see how three-dimensional imaging can help you to understand what the the burden of those rib fractures are. So I mentioned that the flail chest, or what sometimes is called a flail segment. And the reason for it being called a flail segment is because it truly is a segment of the chest wall, and I'll show you that in a moment on a photo, how that really, how that wording has come to be. But the definition of this is not what I have written here. It does not require 4 ribs. Typically, it'll be 2 or more ribs in 2 or more places. And I'm not sure where that actually came from, how that snuck in there when I was making the slide. But in general, what we usually think of as a flail chest is 2 or more ribs in 2 or more places. Okay, because what that does, that creates a segment of the chest wall that is unstable and literally disconnected from the surrounding chest wall. One important thing that can be interesting to see actually is that in someone who's breathing spontaneously, you can actually have what's called paradoxical movement of that segment. So again, getting back to that, the physiology of the respiratory system, we expand our chest volume, and by doing that, we draw the lung to a greater volume, thus bringing air in, creating negative pressure and drawing air into the lungs. Well, what happens here is as that chest volume increases, rather than having it be rigid and dragging that lung out, so to speak, that segment will actually stay in. And so we're taking a breath, chest wall's expanding, and that segment is pulling in. As we exhale, the opposite then occurs because there's a little bit of increased pressure behind that segment, and it actually bulges out. And this is very well described, and many of you I'm sure have seen this in the setting of flail chest, where you have someone who's, again, spontaneously breathing. If you're receiving positive pressure, you won't see this because the chest wall is kind of along for the ride in positive pressure, right? We're driving air in through the trachea and down the airways. The lungs are expanding and just pushing the chest out. Okay, so you only see this in somebody who's spontaneously breathing and breathing without ventilatory support. Okay, that paradoxical movement in itself can compromise ventilation. Okay, so if it's big enough, you're actually have your increased volume of the thoracic space will cause a not quite as large an expansion of the lungs. So it in itself can have ventilatory compromise. But by far, the number one concern with flail chest is the underlying contusion of the lungs. And the reason for that is it took a lot of energy to break those multiple ribs in more than one place. The ribs don't typically do this, right? They typically will break in distant. If they break twice, they'll often break far apart, okay, because of just the angles of a circle and the way in which it's hard to break a circle in one spot, all right? But to take a segment, a section of the chest wall and fracture it requires a substantial amount of energy. And so it ends up being that the outcomes related to a flail chest are often related to the significance of that pulmonary contusion. We'll talk more about that in a moment. One thing that's important is that when a patient's initially seen, they're undergoing their initial evaluation, the imaging will frequently underestimate the size of the pulmonary contusion. The reason for that is something that I'll talk about in a moment, but that's the fact that a pulmonary contusion is some amount of actual bruising, physical, blunt force to the tissue, but it also has a substantial amount of inflammatory response related to it. So the actual disease process continues far beyond the initial insult. So if someone is in a car crash, the steering wheel comes in, causes a flail chest, contuses that lung beneath it, they will have some amount of immediate bleeding into that tissue. But the inflammatory response is something that's significant over the next couple of days. The lungs are one of the most rich areas for cytokines and inflammatory mediators in the body. And for that reason, this isn't just in contusion, this is in ARDS as well, and other pneumonia and other diseases that we battle frequently. The inflammatory response tends to be substantial, and that's no different in pulmonary contusion. So for that reason, you'll look at your imaging, and it won't look as bad as it may in a few days. Okay, and much of the time, we all kind of have that feeling. We know that those numbers of ribs that are fractured, that segment of chest that's fractured is going to, or the energy that went into all that because of all the other injuries that we're seeing is going to cause a substantial amount of contusion. And so when they start to really deteriorate 12 hours in, maybe they weren't intubated and now they are intubated, we understand, we usually understand why. We know that this is their contusion that's fluffing out or blossoming. So it's kind of some of the things that we'll describe it as. So that's an important point. And then, as I mentioned, over time that'll evolve, and sometimes to a substantial degree, and sometimes less so. The challenge on this that is kind of the challenge with trauma as a whole is that everybody's body is a little bit different. So an individual's inflammatory response to a certain amount of insult can differ significantly from person to person, and that has to do with our genetic makeup, and also a lot of the future of trauma care is in this concept of what is the genotype that people possess that causes them to have a minimal inflammatory response or a maximal inflammatory response. And pulmonary contusion is one of those areas where a lot of that interest is in, because it is such an inflammatory type of disease. So just a couple of photos. Here you can see that segment that is dissociated from the surrounding chest wall. Remember, this is all pretty rigid. And so when you have these two fractures in these couple of areas, that really separates. And all you're left with then is muscle holding it. And oftentimes that muscle can be terribly lacerated, because if it broke the bone in this area, it definitely ended up tearing a lot of the muscle. And when we go and sometimes fix these, which I'll talk about in a little while, we can see terribly lacerated muscle, almost completely at times. So it's no surprise that when there's all that's holding this sometimes is a little bit of fascia and maybe the skin, that you would see that paradoxical motion. This one's a little bit, there's a figure of it, but a little bit larger, and gives you again another look at that, how you have these multiple fractures and this segment here that is dissociated from the chest wall. So one can imagine, if you see beneath it where they have this purple color on these on the drawing of these lungs, that's all contused area, okay? Because again, that segment went way into that lung tissue. You know, one of the most disturbing things to see is sometimes when you have real live footage of injuries occurring, how much we see them and they, you know, things are broken, but we didn't actually see the motion that caused those fractures to occur or the injuries to occur. And sometimes the amount of displacement of tissue is unbelievable. And this is no different. This tissue probably displaces 10 to 15 centimeters into the thoracic space upon finally fracturing. So a little video or a little bit of a figure here of that paradoxical motion you see on inspiration, and where the arrow is over here. Again, negative pressure, so spontaneous respirations without mechanical ventilation. So you see how on inspiration, increased volume, and that segment then over here on the patient's right side enters in. It's pulled in because, again, nothing is structurally holding it. And on expiration, you can see as that you can see that the chest wall bulges out. Okay, so we'll get a little bit now into what are some of the ways in which we approach these problems. All right, so you'll see here a figure that gives you a little bit of understanding of what's the problems that we experience with a flail chest. So you see some of the things that can occur: ineffective cough, associated atelectasis, flail segment, the actual segment itself, and then respiratory muscle dysfunction. Okay, what we end up seeing then is retention of secretions through the ineffective cough, that VQ mismatch, that shunt that I described, pulmonary contusion that's associated with these flail chest phenomenon, is a major driver of VQ mismatch, of shunt, of that inappropriate matching of ventilation and perfusion. Also, we see in the increased work of breathing, because we have the atelectasis and this actual segment then that's just not functional. Okay, so it's actually dropping in when we're trying to breathe, and it's not actually contributing to our ability to perform air exchange. Ultimately, then leading to hypoxemia, respiratory muscle fatigue, and then respiratory failure. So this is a figure of what are the pieces that go along with experiencing a flail chest and what that patient's experiencing. So this is that photo I was talking about. This is an intraoperative photo of a flail chest. More importantly, though, it's what I think is interesting to see is that you can see here the substantial displacement of these broken ribs right here. So these rib fractures, this is inside the chest. This is the lung pulled away down here on the right side of the photo, and you can see how the ribs, these three ribs, are significantly displaced posteriorly into the thoracic space, and you can imagine then these sharp areas of bone and what they would do to a lung. So this is the reason why this person develops a pneumothorax, tear their lung tissue beneath it. This is the reason why they develop then a hemothorax, because they bleed from those lacerations that occur. It's the reason why they need a chest tube then. It's the reason why that chest tube makes it even harder for them to breathe. Why they then potentially may need surgery to evacuate retained hemothorax. So you can kind of see how all of these things occur and stack up in patients that have these severe chest wall injuries. So I can't leave out the sternum. It's not a major player in this, but it is definitely a bony structure within the chest wall. Not uncommon injury. Fortunately, not one that in itself causes a great deal of problem. It's recognized when you have severe pain on sternal palpation. As with many injuries, this is one that could be indicative of a severe underlying injury, particularly a contusion to the heart. So it's right on top of the heart. It's in itself a pretty strong bone, and so it takes a decent bit to fracture the sternum. The seatbelts are pretty good at it. When they cross it, they tend to then create a line across the sternum and can end up with a sternal fracture. Mainly, we're interested in other injuries. You can see here a couple of things that are done if it has to be fixed. In most cases, they don't. They're usually they spontaneously heal in most cases. Pain control-wise, if you have people that have an isolated sternal fracture, which is not terribly common, usually pain control-wise, these aren't too bad. Those of you that work in cardiac surgery and do sternotomies and deal with people with sternotomies know that the sternotomy is a reasonably well-tolerated incision. And so even though we divide the sternum down the middle, it's oftentimes better tolerated from a pain standpoint than actually thoracotomies, where we're spreading ribs laterally. And so sternal fractures tend to behave similarly. So even though that you'll have a sternal fracture, usually there's not a great deal of respiratory compromise related to a fracture of the sternum. And so just a figure there. And this is a good one that kind of shows you that many of these are going to be a transverse fracture across, because it's a long, narrow bone. That seatbelt comes across it and just pulls right in on it. It's relatively, and I say that because this is cartilage beside it, but relatively fixed. Therefore, when a seatbelt protrudes, it'll cause that transverse fracture. Okay. So now moving on to pulmonary contusion. Already discussed some of this, but getting a little into some more detail. Most of the time, pulmonary contusion is secondary to blunt trauma. It's secondary to blunt force to the chest wall, with or without rib fractures. As I described, the younger we are, the more likely it is that the ribs just bend and the lung still gets contused beneath it, right? But you definitely can have it with penetrating injury. Stab wounds, much less common, but with gunshot wounds, there can be a substantial amount of energy, and they can be a significant pulmonary contusion associated with gunshot wounds, particularly in the areas surrounding the missile tract. The results are, as I described, VQ mismatch with shunt. And so we have, again, issues with matching of our ventilation with the perfusion. And in this case, we have poor ventilation in relation to perfusion. And that then ends up resulting in hypoxemia. And so hypoxemia ends up being one of our bigger concerns, as oftentimes I know in your head when you're approaching someone, it's, do I have a problem with oxygenation or do I have a problem with ventilation? And this ends up being a major player, or both, but major player in in the world of oxygenation. So hypoxemia and rapidly progressive severe hypoxemia can be one of the features of pulmonary contusion. As I described, over the first 12 to 24 hours, these can worsen. As that inflammatory response really gets up and rolling, a lot of times these injuries can worsen. And we're somewhat interested in what they look like on imaging, but we're really interested in what they look like clinically, or what they look like in terms of their respiratory function. And so when I say worsen, it's not as much that all of a sudden their x-rays now are whited out, or they have a significant amount of changes on their imaging, but more so they have increase in their oxygen requirements, they have increase in their work of breathing, they have challenges that then require initiation of mechanical ventilation, etc. Ventilatory support is provided if needed, and there's plenty of patients that have pulmonary contusion that are of lower degree that don't need very much, but then there are plenty that do. What we're going to talk about in a moment that's really important is early on with the airway clearance side of things, that bronchopulmonary toilet is of critical value. And also then pain control, and I say that not because the lungs themselves hurt, but usually these are going to be associated with rib fractures. And so that lack of when we have challenges with pain control, then we have challenges with our bronchopulmonary toilet and our airway clearance, thus leading to the complications. And what we really are worried about from a complication standpoint is pneumonia. By far the most common problem that we run into when you can't, when you have a bad contusion and you have compromise of your ability to have adequate airway clearance, and bronchopulmonary toilet is the development of pneumonia. Okay, and then commonly you'll see the course of people is they have pulmonary contusion, they had respiratory compromise from that for 4 or 5 days, and then they have pneumonia, and then they have respiratory compromise from that. And so they segue right from one into the other. So you can see again just a fairly simple figure here of the contused area of lung within this within the right lung. You can see a little bit now, we'll talk about it in just a second, but in comparison between normal lung tissue and contused lung tissue. Microscopically, oftentimes what you're seeing is bleeding into the alveolar spaces with then subsequent development of edema. So there's oftentimes the key piece of this is an obliteration of those air sacs, those airways that then we depend so much on for air exchange. So as I mentioned, bleeding and edema are the initial, initially it's bleeding, right? So you hit something, oftentimes that bleeding can occur rapidly, but then as that inflammatory response kicks in, things swell, and when your lungs swell, they don't necessarily enlarge, like if you hit your thumb with a hammer, it grows big. When your lungs, right, we have edema, but it doesn't cause the same sort of swelling. It fills those air sacs, and so we have pulmonary edema, but importantly, like in the setting of ARDS, this is non-cardiogenic pulmonary edema. All right, and we'll mention it in a little while, but this is not pulmonary edema that benefits from diuresis, at least during the initial phase of management. In fact, patients that get diuresed with the thought that they have pulmonary edema do worse. If you look at large series of patients and you take people with pulmonary contusion, you try to limit their fluid through either just fluid limitation or through diuretics, they don't do as well. So it is one of those things, and there's lots of things in medicine where they just make theoretical sense that, well, we got an edema problem. Clearly I need to get rid of edema. I know I can get rid of edema with diuretics. It ends up being the opposite. And the reason for that is that the patient is going through, when they're having this inflammatory response, the last thing they need is poor perfusion to any tissue. The way in which they recover from the inflammatory response is to have adequate perfusion and allow the healing to occur at the cellular level. So when we pull fluid off, what we do is we actually disrupt perfusion, we compromise perfusion, and we increase the likelihood of that inflammatory response continuing. So that's the reason why then if you look at patients across the board, then they have worse outcomes. As I've described, they have ventilation perfusion mismatch. What they experience is pulmonary hypoxic vasoconstriction with increased vascular resistance. So as those alveoli don't get the oxygen that they need, all right, remember one of your most potent vasodilators in the body is oxygen. Lots of you use other ones that we provide medicinally, but oxygen is probably the most potent vasodilator that we have. So when you now don't have oxygen in those air spaces, what you end up experiencing is vasoconstriction and increased vascular resistance, and that ends up being a problem in itself from a blood flow standpoint. And so often this is one of those times when you'll have issues with perfusion that are directly related to issues with your pulmonary function. And when you can get the one fixed, the other one tends to respond as well. Because it's shunt, and because this is a phenomenon where we can't get that oxygen down to those air spaces, oftentimes just providing oxygen won't help. Okay, and it ends up being something that requires more than just the presence of increased oxygen in for attempting to force that into the spaces, but rather more of an opening up of those air spaces, and honestly, a lot of it just being the healing process that's required. Another photo here, you can see, as I've described, you see your normal airspace, okay, and you can see here this venous congestion that's causing poorly oxygenated blood to return from the lungs, okay, that VQ mismatch, that shunt we experience. And so you can see another figure here that shows it again, that more of a subsegmental level. You can see here a photo of what they look like on, what this looks like on CT, okay. This looks like a consolidation. So one of the things, that's always tough about the lungs is lots of things just look like a consolidation, right? Pulmonary edema looks like consolidation, pneumonia looks like consolidation, contusion looks like consolidation. And so one of the things that, and one of the big ones is atelectasis looks like consolidation. So in fact, if you look at this, and I initially looked at this is maybe contusion, but it also may be atelectasis, right? We have it on both sides, around the back. And so one important point when we look at imaging, three-dimensional imaging particularly, and try to deduce whether this is a contusion or this is somebody's laying on their back for a while and they have atelectasis, is the location of the consolidation. And what I mean by that is we have fissures, right, that separate the lobes of our lungs. Atelectasis does not cross fissures, okay? Contusion does. Think about the segment. Overlying the segment doesn't care whether there's a fissure there or not. It's contusing everything that's behind it. So impact, broken ribs, contusion of the tissue behind it. If there's a fissure across it, it doesn't care. It's gonna injure the lower part of the left upper lobe and the upper part of the left lower lobe. It doesn't care. So one of the ways in which we can tell whether something is a contusion versus just atelectasis is to whether it crosses the fissure. And so it's one of the things that we look for. But in general, it then tends to be somewhat difficult, and you end up needing to take into account all the information. Okay, they have broken ribs. They have an area that is there, right? That's coinciding with my rib fractures, and I've got pulmonary compromise. I think this is contusion. It's kind of, again, with as we do with a lot of things, it's a matter of bringing together all the data. So I won't get into this in detail, but I wanted to put this up because this lets you gives you some understanding then of this inflammatory response. You can see here the description of the neutrophils and the endothelial cells and fibroblasts and how they make various different cytokines. You can see that listed below, the TNF alpha, IL-6, IL-10, etc. Again, I'm not gonna get into that, but the important point here is understanding that pulmonary contusion is very much so an inflammatory disease process. It's one that is driven by the presence of inflammatory mediators, not just like a broken femur where something struck it broke in two pieces, and we need to fix it and get it into one piece, okay? Very minimal amount probably of inflammatory in relation to a pulmonary contusion with something like that, all right? The lungs are loaded with cytokines. They're loaded with other inflammatory mediators. They don't like having things done to them, and they release their inflammatory milieu when confronted with some sort of form of injury. And the issue there is just that it doesn't end quickly. It tends to have some time basis to it. So let's go into a little bit of what are some of the things we do about these problems. So just getting back now, starting back with the chest wall injuries themselves, particularly then the more simple rib fractures or even a number of rib fractures. We begin, every time we talk about it, remember, trauma patients always go back to the ABCs, and in fact, in this case, it is important, particularly the establishment of an airway. All right. Some people very quickly will have major problems by the time they even get to the trauma center with their respiratory function, and they'll need an airway immediately, and they'll need assistance with ventilation. Okay. Sometimes, though, it progresses, and we need to establish support in the days that follow, and so we need to be sure that we're capable then of recognizing that and establishing that airway when we need to. But as all of you know, establishment of that airway is critical. Here's a very important point, though. There has been over time a thought that is somewhat out there in the world, especially at non-trauma center locations, that pulmonary contusion, flail chest and pulmonary contusion require intubation. If they just require intubation, you see that is one of those indications for intubation, and go ahead and just do it. Okay. It's important to know that more recent, and it's not even that recent, it's over the last at least decade or so, it's been very well recognized that you don't need to do that. All right, there's plenty of people that'll have these problems that will not need initiation of mechanical ventilation, and that probably has a lot to do with that difference in the genotypes of people, the way in which people respond differently depending on what their makeup is, what their genotypic makeup is, and I think that's why you'll see that's not all trauma patients are created equal from that standpoint, even with similar injuries. Supplemental oxygen, of course, is almost always supplied in this case, sometimes more effective. We're probably oxygenating healthy segments more than we're actually oxygenating the hurt areas, but that oftentimes will drive up your PO2 to a point where you'll be okay. So supplemental oxygen can still be helpful depending on the extent of your contusion and the extent of shunt. And then, of course, basic airway adjuncts continue to be valuable depending on the situation. So for rib fractures, the big things that we think about right out of the gates are pain control as being probably the number one. Pain control, and then bronchopulmonary toilet and airway clearance being right there with that, because the pain control is important to allow the other one to occur. In actuality, the pain control is not as important really as the second, but we know we can't achieve the second there without the first, and we don't want people to hurt, of course. So pain control ends up being the immediate number one priority, with then knowing that when we're able to achieve pain control, we're able to achieve adequate toilet and airway clearance. Okay, in most cases, that is all you need, as long as that's adequate. And we'll talk a little bit about the adequacy of that in just a moment. But as long as that's adequate, most of the people will get better with just that. Almost all ribs will heal without any intervention. Okay, and we believe that many people do just as well allowing them to heal on their own as they do if we fix them. Okay, and so the next thing that we do think about from time to time is rib fixation, is actually opening the chest up, finding where the ribs are broken, and putting plates in to actually fix the ribs. I'll show you a couple real quick of just some of the papers on that in just a moment. But I'll tell you, the bottom line is we really don't know. We really don't know the role of rib fixation. We don't know how effective it is. We think that in the setting of advanced rib fractures like flail chest, that it has a role. I'm just not sure if it has roles in other areas, because there's several aspects to it. There is the getting off of ventilators. There's, of course, survival, if by chance it would be beneficial in there, but there's a lot being looked at. Can we get people off ventilators quicker? Can we get them out of ICUs? Can we get them out of hospital? But then there's even if you have 3 or 4 rib fractures, there's the getting people back to work and getting them back comfortable, getting them to avoid narcotics, which we know is a problem. And so, So we're really not sure whether we're kind of the role of that right now, and again, there's a decent bit of work that's being done from that standpoint. And then of course there's the mechanical ventilation side of things, that, and I'll talk about that in just a moment. Pulmonary contusion tends to be very similar, but really with the airway clearance and toilet side of it being important, and then figuring out whether someone needs respiratory support. From a pain control standpoint, IV narcotics, mainstay in the beginning, patient-controlled analgesia buttons, transition quickly to oral narcotics, especially right now when we don't have a lot of IV narcotics around. Okay, regional anesthesia, epidural catheters have been shown to have mortality benefits in certain populations that get them. So we're oftentimes, with any more than 3 or 4 ribs, we are immediately looking to see whether we can get an epidural catheter in someone. Okay, non-steroidal anti-inflammatories are fantastic. Unfortunately, when you have other orthopedic injuries, we oftentimes don't like to provide them because of concerns about healing, and so they often don't get to be used, but they are phenomenal adjunct to narcotics and decreasing the amount of narcotics. Because we want to consider that that's the reason for non-narcotic analgesics, the use of muscle relaxants for spasm. People oftentimes have spasm, and that can help quite a bit. And even then, the use of ketamine, because we're trying to reduce, in many cases, particularly in the older population, how much narcotic we use. And in the younger population, when people that become addicted, we also want to think about that from a long-term standpoint. Airway clearance, I don't need to talk a whole lot about you, or talk to you a whole lot about this. This is what you do, right? And it's critical. And this is actually a slide from my talk that I gave a few years ago on our evaluate and treat that we do. This is actually just from that, where you can see what's there. And this is something that we oftentimes trust all of you to provide us with insight. What do we need to do for bronchopulmonary toilet and airway clearance? Okay, so I'm not going to get into that, but I can't stress enough the importance of that on a frequent basis in the beginning days of someone having pulmonary contusion. You know, you guys all know these all so well, I'm sure, right? And then you can't forget then the medications that are required, because remember, not everybody coming through has healthy lungs. Unfortunately, a lot come through the door that don't have healthy lungs, that require some form of medication for chronic lung diseases. So that's another important part. I'll jump through these pretty quickly. This is all about rib fixation. In this study, rib fixation within 10 days improved outcomes. In this one, decreased ventilator days with rib fixation. This one reduced ventilator requirement and ICU stay. So again, these are kind of the studies that are going on right now to try to figure out, do we fix ribs? And a lot of it being done in flail chest, low-hanging fruit, because these are the sickest of the patients. Just a flow chart here. We assess our airway and oxygenation for flail chest. We assess the ability to cough and clear secretions. If they're unable to, we initiate aggressive pulmonary toilet. I would say even if they are able to, we still look in on that and make sure that they're able to. We look into epidural catheters and evaluate frequently. As you can see below, the risk of pneumonia is high, and mechanical ventilation is likely to be needed if cough is not effectively achieved. Okay, so a lot of this goes back to then achieving an adequate cough, an adequate clearance of the airway. As I've said, pain control and airway clearance for contusion. Early initiation of ventilatory support if needed. So the point there being, we don't let people get behind on this. We don't need to intubate them necessarily early, but we know that this is not a rapidly reversible problem. So that's why the next line as well, there isn't a great deal of role for non-invasive mechanical ventilation. Within our experience, we find that these things go on for days and days, and that's oftentimes, usually we like non-invasive options for fairly rapid turnaround types of problems. These are not those types of things, and so we find that there's a limited role for that, and that we want to make sure we don't get people in trouble before initiating mechanical ventilation. And as I mentioned, the therapy is really toward improving oxygenation. No mode is superior. But the basic principles hold true. We don't want to injure lung tissue by the therapy that we're providing. So we will limit excessive pressure and volume. You may need higher levels of PEEP, because PEEP is valuable at fighting shunt. Okay, it's a valuable adjunct. And really what we're talking about is increasing mean airway pressure, and PEEP just does that. So other things that would increased mean airway pressure are going to be valuable, as well as PEEP. Commonly will initiate volume-controlled ventilation. We'll transition to pressure-controlled modes as necessary. And again, things that would increase our mean airway pressure, extension of I time. APRV is another one that can be used. And then we continue to monitor after we're able to achieve successful oxygenation. And of course, some patients need ECMO. This is one area where we've had plenty of patients with bad contusions that end up on ECMO and do actually very well, because it's again, you get them through that inflammatory response, those lungs heal, and they're able to come off with rest and do real well. These are the EAST guidelines, just to sum them up real quick. The support that you use is oftentimes what you have from an institutional preference. That's what's important. And it gets down to the bottom, which is self-activating multidisciplinary protocols. Do things consistently and do them well because you're doing consistently. Get people off the ventilator as soon as you can. Not really rocket science there. PEEP or CPAP should be provided. Consider high-frequency oscillator ventilation. And then they even described independent lung ventilation. So this is one of those phenomena where you're really hurting one lung to ventilate all of the same, and they're not the same, and considering independent lung ventilation. We'll skip over that. Okay, so to conclude, we've talked a lot about chest wall injuries and pulmonary contusion, and just to have you recognize they're very common, something we have to deal with all the time. They can be severe, leading to significant physiologic deterioration and derangement. Pain control and airway clearance are the mainstays. It's really what we're really needing to focus on. And then those severe injuries may require mechanical ventilation with the aim of improving oxygenation, while again avoiding further injury. So thank you all for your time. Really appreciate it.
Questions? We got a couple minutes. Any questions?
Anything?
Nobody wants to talk about it?
Covered it all?
I have a question.
Oh,
Yes.
Here we go.
So, a couple of years ago, I was working on my truck, leaning over my truck to change, I think, the valve on the alternator, and I felt a, kind of like, oh, what was that? That's still bothering me.
Do you feel it? Do you feel it moving? So here's the thing on. I said most heal. A small percentage do not, and they would have what you would call in the orthopedic world non-union. So that's when two pieces are still separate. They actually get cortical edges to them, so they're on their own little bone now. And with rhythms, what you'll feel is them moving, and that is then usually an indication of non-union. And it actually sometimes is. For some people, we would fix that. We'd actually go in, take a little bit of that edge out, drive the bones together, and put a plate across it. So that is, you may have experienced then a broken rib and non-union. Do you need a clinic appointment?
I guess that's what's happening, because it's not going away.
You need an appointment now?
Yeah. It's one way to get one.
Yeah, that's right.
Via a full room of people. I think our HIPAA just went away, but.
That's right.
Yes.
Are you for or against mandatory seatbelt
Seatbelt use? I thought that question was answered. That's absolutely seatbelts. There's no question whatsoever with seatbelts. Oh. Absolutely. No. Sure. Except, yeah, the reason why we're able to see these injuries now is because of seatbelts. Usually these people didn't make it to the hospital or didn't even survive long enough, and it was much, much greater. No, the injury, we don't see severe car crashes like we used to see 10 years ago. Now, one of the big things, one of the first things was seatbelts, then it's been airbags. But the vehicle safety is unbelievable. It's the reason why our populations now are a lot of elderly falls, is because cars are so extraordinarily safe, and seatbelts are a critical part. It's a great deduction to say, we spend a lot of time talking about how the seatbelts do all this. It's so minimal in comparison to the alternative injuries that you would experience without them. All right.
All right.
Well, thank you.
Thank you. Shane.
Me?
That's what they give.
Thanks a lot.
I appreciate it. Thanks again.
I need to put ours in.
Okay. Oh, Lord. You're asking me to do it. Tap to choose.
So this is the mic that she has to talk into so they hear her next door?
Well, actually, either one. This one, or you're probably going to want that.
Well, Dave said that doesn't talk in there. That one doesn't transmit into the other room.
This is the one Shane just used.
Oh, but he stood at the podium too, though, right?
Yeah, this one's on, but this is the one he used the whole time.
Oh, okay, good. Good. Then
Just
you can
put
do
this.
that.
Well, I don't know. I mean,
Now, why
people were
isn't my
putting it
thing
there. It was
pulling
really,
up?
really loud.
Why isn't my thing pulling up?
Well, let's see.
Oh, here it comes, maybe over here. No?
Uh-oh. Is yours?
It's encrypted.
It's encrypted?
Yeah. I made Colleen write down my password yesterday. I can't be responsible myself. I have to have a keeper.
Oh, it's not even showing up.
Go click down there and see. Yeah, there it is. That's so weird. Now, isn't this going to be a mess?
This is what we've had all day, so it's not anything different. Look, I'm gonna make the boss come since he left.
Good.
Why is it?
Why isn't it showing up?
All right, this one's encrypted. Why is it not showing up, Barney?
Like it's not
And
pulling
then,
up so
and then
we
you,
can log
I pull it
in.
here. Yeah. And I can't find it.
No, not that one. That. Yeah.
That's the data traveler.
Uh-huh. I'm traveling with data.
So right now the camera's just on the screen. Colleen's here in case you don't know.
I know, I got it.
Oh, yeah, somebody coming to watch you now.
Huh?
Somebody coming to watch you. So what is your title, Jill, other than RN?
Manager of Patient and Family Center Care.
Thank you.
And I didn't write stuff down because
I know, I was like...
he was going to install. He was going to say.
Yeah, and you know what he did? He just walked out.
I know he said he was doing it. I'm ready to do it. That's all right. You just say whatever about me that you want to. I'm a big girl and I'm taking it.
I want to know what your title is. What is it again?
Manager of Patient and Family Center Care. Patient and Family Centered Care.
I'll write it down. I don't remember it at all. Look at the other thing in the turret.
I did that. So don't say that. Just say she's a patient.
Does she have a volunteer?
Did you do that?
Yeah.
Some areas would be a lot better if you can stay like in this general area back there. Because Dave had a lot of their mic on, really couldn't hear.
Is she gonna speak too?
Yeah.
Together?
Yeah.
There. There she got fired.
So I'll be using that one and she'll be using this.
Um,
I'll stand right where you are when we start.
are you know how to move her and shake her? Julie's runs around.
Yeah, she's a runner.
I know. Okay. All right, everybody. We'll have closing remarks in just a little bit. These are our last speakers of the day. They saved the best for last. Yay. And they're going to be talking about the patient and family experience and the and important roles of RT with these particular roles. And this is going to be, there's going to be two of them. Julie Barnes is one of our speakers. She's an RNSN. She's the manager of patient and family centered care at the hospital. And Judy Pardue, who's a patient and family advisor with Wake Forest also. Has had many other roles there. So I'm going to turn that over to them, and there's you.
All right, thank you. How do I advance?
Yep.
So good afternoon, everyone. We are so excited to be here with you. Jody and I love respiratory therapists.
We do. We really do.
We do, right? I love respiratory therapists so much I married one. No, but really, I went right into the ICU as a nurse, and so there are so many folks that I see around the room today. Donna and Beverly and Kevin and Brian, lots of folks who are here today who really helped me grow, helped me learn. They trained me as a baby nurse, if you will, and really helped me learn what it means to be a good caregiver and how to really take care of patients. So I'm thankful to have the opportunity to come back and share with you guys today. So I know it's been a long day. I know you've heard lots and lots of stuff. So we are not going to lecture you for the next hour. We're going to do lots of different stuff. You're going to hear lots of stories. I'm a roamer. I like to move around, but I'm trying to stay near this space. So bear with me as I'm trying to figure out where I'm going here. But you're going to hear stories. It's also going to be participative though, right? So we mean for this session to be interactive. I am going to ask you to participate with us. I'm not going to make you stand up and answer questions out loud, but I do want you to interact with one another. Okay, so not scary stuff. So today, during this next hour, we're going to talk about what is the role of the respiratory therapist in the patient and family experience. And then we're also going to talk about patient and family-centered care and what are the 4 principles that define patient and family-centered care. So just quick, down and dirty, I want you to have a definition of patient and family-centered care. Basically, it just means that we're working with patients and families and not doing things to them or for them. So what you're going to see today, Jody and I are here together. Jody's a patient and family advisor at our hospital. She's had lots of experiences in her own care and the care of her children across our medical center. And so we want to model for you what it looks like to co-teach with a patient and family advisor, right? So it's different than if I came up and I just wanted to share the things that Jody wanted me to say. That'd be speaking for her. But we really want to do this together. This is an example of doing with patients and families. So you're going to see us kind of trading off as we go back and forth throughout the hour. All right, so you ready to get going? You ready to participate? Okay, we got your first activity. I'm going to turn it over to Jody.
All right, I am not a roamer. I'm going to stay right here. All right, so this is just a casual activity to kind of get to know each other a little bit. So if you will look in your folders, you should have like a piece of cardstock, a plain sheet of paper. Pull that out when you find it, along with, make sure you have something to write with. And if you don't have one, raise your hand and we'll make sure you get one because we have extras. Anybody need a piece of paper? All right. So this is the name game. So what's in a name? We're going to talk about this a little bit. The first thing I want you to do is write your name in the middle of that piece of paper. And then all around it, on the rest of the outside, you can use either pictures or words to describe yourself. We have a picture, a description. So here's an example. Put your name, kind of who you are. If you were introducing yourself to someone new today, how would you describe who you are? So just take a couple minutes to yourself and kind of describe yourself on that piece of paper.
You don't have to have a life motto. We just wrote that as an example.
It's an idea, right.
So don't get stressed out. You have to have your motto.
Oh, I have a motto, it's the other part.
You can get creative too. Draw a nice picture if you feel. If you're artistic. Okay, while you guys are finishing up, I will introduce myself to you with my card. So my name is Jody. I am a daughter, a sister, a wife, and a mother. There's my little family down there at the bottom, my husband and myself and our 6 children, one of whom is an angel. Our 5th child passed away, so I have angel wings on him. I like to think of myself as a good friend. That's important to me, to have good friendships in my life and to be a good friend. I have the sunshine because not only do I like to be outside in the sunshine, but I like to bring sunshine. So smiling is important to me as I engage with people. I love to share love, and I hope that people feel that from me. And I'm a student. An old student, don't judge. I'm an MSW student. So that's me. So take a few minutes and kind of turn to the folks around you, 2 or 3, 4 people together, and kind of go over and introduce yourself. And you may know each other already, but you may learn something new in this process too. So take a couple minutes and go over your card with the folks around, just real close around you. Okay, has everyone gotten a chance to introduce yourself?
still got it. It'll take another minute.
Yeah. Yeah, take another minute or two. Make sure everyone around in your little area has had a chance to introduce themselves to you. You didn't get to talk in class much today, did you? Okay. Good. So some of you may have known each other. Most likely you know some of the folks sitting around you. Did you learn something new about someone that's sitting near you?
Yeah, I do.
Yeah. Yeah, so let's talk about some of the things we use to describe ourselves. How many people use like a job title or a career to introduce yourself? How about something relating to family? Yeah. Any character qualities? Positive, I assume, but if you wanted to put like lazy or irritable, I doubt anybody did that. How about character qualities like that you're proud of? Yeah. Good. So we all have that in common. Did anybody use like a disability or a diagnosis to describe themselves, to introduce themselves to the folks around them? Nobody? Not like arthritis, irritable bowel syndrome, obese. No, we don't describe ourselves that way. And so that's something that it's really helpful for us to keep in mind when we're engaging with other people. Very often I feel like as a patient, when we're working with patients in the hospital setting, very often they're described as their diagnosis, right? Whatever that is. There's so much more to know about each other. So as a patient and a family member of patients myself, it was important for me to be known when I was in that setting. And it's really helpful to know each other, even with coworkers. It's helpful for us to know each other in a positive way when we're working side by side, instead of just describing like, oh, here comes that cranky old guy and I hate working with him or whatever. But it's so easy for us as humans. I feel like it's our human nature to make assumptions about people and kind of get these judgments about who they are. I've been in that place as a patient and a family member before as well. I've been on the end where I've had positive interactions with folks. As a parent, I've also had one story that makes me think of where an assumption was made about me, and I knew it. With my youngest daughter, who is now 9, just before she was 2, she got really sick, and 3 trips it took us to the emergency room, and we were sent home. But 2 of those trips to the emergency room, this is what we got. Is this your first child? She just has a virus. Go home and wait it out. And the assumption that was made about us was that I'm the overreactive parent. My kid has a sore throat and I'm coming back to the emergency room again. And what they didn't know about me was she was my 6th child. Just 2 years earlier, I had buried one of my children. My oldest son had leukemia when he was young. And so I was kind of a seasoned mom in the medical setting, and I knew something was really wrong with my daughter. But that interaction kind of seasoned our whole experience in that. And when I still think about those visits to the emergency room, I knew they didn't believe what I was saying, that something was wrong with my daughter, and they thought I was overreacting. And so that changed everything. And so Julie's going to talk a little bit more about that, the experience of the patient and the families of patients.
So when you guys hear that term, patient and family experience, what do you think that is? Do you think it's the same as patient satisfaction? No, like patient experience is kind of the trendy term right now, is what we're saying. But is it the same as patient satisfaction? Close? Could be.
It should be, but it's not necessarily, your experience is not necessarily satisfying.
Yeah,
but
so
it should be.
Your experience is not necessarily satisfying. So we often get asked, hey, can you come and talk to me about patient satisfaction? And usually my answer is no, I can't, because we're not really in that business of making people happy. We are in the business, though, of caring for people right? Of helping them get better, of helping them learn about their illness or their injury, and really helping them feel cared for. And that's different than doing things that just make people happy, right? So if you take me, for instance, I love a chest x-ray. I love a chest x-ray, right? So I told you I grew up in the peds ICU. That's where I learned to be a nurse, in the peds ICU. And so there, if these babies were intubated, they got a chest x-ray every single morning. So I was very comfortable with a chest x-ray. It's what we did. It's what I'm used to. So fast forward 10 or 12 years later, and I have my own children. And so while they're sick and coughing for weeks on end, I really want a chest x-ray, right? I like a chest x-ray. I want you to look and see and tell me what is happening in there, because that cough is horrific. And I live with a respiratory therapist. I really want a chest x-ray. Can you just do one? I could never get one, and I was so frustrated. And so I talk a lot about how my pediatrician really talked me down and explained why I didn't need a chest x-ray, or why my kid didn't need a chest x-ray, right? She talked me through what she was seeing clinically, what she was hearing, why this chest x-ray could offer more harm than good with the radiation to my baby or my little boys, right? I didn't really need a chest x-ray, and I'll tell you that the one time I did get one, it was beautiful. There was absolutely nothing on there. I've never asked for one since. So the things that would have made me happy were not really what I needed, right? So that's different. I walked away, though, every time from those experiences. Even though I didn't get what I thought would make me happy, I did walk away feeling positive about the experience, because she talked me through it. And I understood her recommendation, and I understood that she was on my team. I didn't feel like she was blowing me off. I mean, she had the whole conversation with me. So I felt cared for, and I felt like we were in a partnership together. I knew she cared about my children. And so that's the difference. We can't always do things for patients that will make them happy. They often ask us for things that are harmful, quite honestly. And so that's not really what we're in the business of, but we are in the business of creating a positive patient experience for folks. So there is a difference. And how do we do that? Well, we create a positive, actually, I'm getting ahead of myself. So the Barrow Institute describes the patient experience with this definition, which I just love. So it's the sum of all interactions that's shaped by an organization's culture, that influences patient perceptions across the continuum of care. What I hear repeatedly from patients and families is that I can't really separate an experience. Like, it's hard for me to just talk about what happened in the emergency room before I got admitted into the floor, you know, or into ICU and then to the floor. It's all one big experience. Jody tells me that over and over. It doesn't matter how many times I'm asking her about stuff, she'll say, you know, I can't really separate that. Like, it's all one big thing. It all blends in together, and this definition tells us that. It also tells us that we're all responsible, that it's every one of us. And so I think as respiratory therapists, you guys have such a tremendous opportunity to impact the patient experience, no matter where you're encountering them. Even if they've had some negative experiences before, your positive interactions with them can totally turn that experience around, because it's the sum of all of it, right? So it's everything pieced together. The patient experience doesn't just start with your interaction. It's all the things that happened before. It does not just start when they pull in our parking lot or when they enter into a unit. It starts in the community. It's word of mouth. That starts to build, right? Reputation influences the patient and family experience. So how do we create a positive patient and family experience? Well, we do that when we practice in a patient and family-centered way. So I gave you the quick definition earlier, but really, patient and family-centered care is a direct effort to communicate to patients and families that they are an integral part of our team. A direct effort to communicate that we're on a team. It's a partnership, right? And so when we work that way and we're communicating, we're putting these 4 principles into play, patients and families can hear our expertise, because you're experts. You're bringing that clinical expertise to the table, but they're also going to be able to feel our caring and our compassion for them. And that's what begins to make the difference. Whoops, went too far. Okay, so we're going to talk about each of these principles a little more in depth. So the first one is dignity and respect. So where caregivers listen to and honor patient and family perspectives, choices, knowledge, and cultural backgrounds. It's a whole lot of stuff in there, and I think when we talk about dignity and respect, we tend to go right to, oh, this is about being nice. And so I got that one, I am a nice person. Of course you are. That's why you're in healthcare, right? So we all are nice people. It's what we do. We take care of people. This is so much more than that, though. And I'll tell you, I learned from the daughter of a patient when she described her experience with her dad about how just being sick and being in the hospital, he was bedridden, he couldn't shower, he couldn't shave himself. There was a point where he could not feed himself. Just the fact of him being sick really made him feel stripped of his dignity. It wasn't anything anybody did to him. It's just this place that he found himself in. And I'll tell you that in all my time at the bedside, I don't think I ever appreciated that. That just being in the hospital can sometimes make people feel this sense of loss of dignity. And the other thing is about respect. Are we respecting the history of our patients? Are we remembering the human moment? You guys, we're taking care of human beings. We're human beings taking care of human beings. And we have to remember that. No matter what put this patient in front of us, even if it's poor choices that have landed them in front of us, they're still a human being. And when we can connect with that, it's more gratifying for us, and it makes a tremendous difference to our patients and families. So I want to tell you a quick story about my friend's dad. The same man, actually, who felt this sense of loss of dignity of being in the hospital. So he had been really sick. Like his whole life, he had worked 2 jobs, sun up to sundown, providing for his family. He got really, really sick, was in respiratory failure. He was ventilated and trached for weeks and weeks. He ended up being moved out of our hospital to a long-term care facility, like where we were doing some vent management and trying to wean him off the vent. And so she was not happy about it. She didn't want to move there, but they did. And she encountered this respiratory therapist. She happened to be with her dad that day. And the respiratory therapist brought in the Passimir valve and put on her dad. And so the therapist was staying with him because it was his first time wearing the Passimir, and they had not heard his voice for weeks. So this was the first time. And he began to talk to his daughter. I just talked to her about it this week, and she teared up again telling the story about how meaningful that was for her to hear her daddy's voice. And she cried, and she said, you know, that's one of the last times I ever heard him. Because he got sick, you know, again, not long after that. It's one of the last times that I heard him, and how special that was. But the really special part was that this therapist stayed, because she had to, right? But she was staying with them. But she looked beyond just what her task was, and they were talking about who did he really want to talk to? Well, he wanted to talk to his wife. She said, well, great, let's call her. So she got the phone, she handed him the phone, he dialed the number, and my friend said, it was the cutest thing. My mom answered the phone, and he said, do you know who this is? And you could hear Mom cheering on the other side of the phone, and she said, of course I know who it is. And my friend says, you know, that therapist who was with us that day, she didn't know that they'd been married for 45 years. She didn't know that my mom married him when she was 16 years old, and they've been together this whole time. She didn't know that it had been weeks since we had heard his voice and how meaningful that would be. She said, I just know she had no idea how much that simple act made such an impact on us. And it wasn't just the phone call, but y'all was letting him dial the phone. It was that whole experience. And so I said, you know, what would be your message? I'm going to talk to a group of respiratory therapists. What's your message? She said, it's about getting back to the basics. And it's about choosing to make a difference for somebody. She said, you can come in and you can just do your job and you blend right into the walls. Or you can choose to make a difference and then you stand out. That's a good patient experience. All right, so second principle is information sharing. So this is where caregivers communicate and share complete and unbiased information with patients and families in ways that are affirming and useful. So really, Do patients and families understand what we're telling them? Are we using words they can understand? Are we speaking our medical jargon? And so I want you to think about that, right? Because we would often go back and say, oh yeah, the mom's asking about the stats, right? Right? We joke about that. They don't know. They hear stats all the time. Sports have stats. That's what they're reporting out. Right? So we want to help them. Use words that they can understand. Explain what we're looking at. Right? Not the words that we take for granted. So think about health literacy. You guys, people who can read and write aren't necessarily able to understand the information that we're giving them. I don't understand information from different departments, if you want to know the truth. Right? So speech therapy sent me their list of goals for their department. I just had to laugh. I thought, well, I don't understand any of this. I can't come and talk to you about your goals. I'm just going to have to do something else. You're going to have to incorporate your goals into that. I can't do it because I don't know what any of these acronyms mean. It's funny, I've been an ICU nurse for 21 years. Like, I know some stuff, but I didn't know anything about that. So we want to be sure we're communicating in ways that are meaningful for people. Do you know the other information that your team members are communicating? Right? And being able to clear some of that up. What you see in the picture is my husband and my little boy. So I had my own experience with information sharing this week. Luke is 7. He was diagnosed with pneumonia earlier this week. I will not talk about that. But so when we were at the doctor's office, we had 3 different people come in and talk to him about using this spacer. So he's used to taking albuterol, but this QVAR is new, and so they're bringing that in. We got a new spacer for that, and she's talking us through the process. 3 people came in, right? And he's old enough to understand some stuff. So he's hearing it. We go home. Luckily, we have our own therapist at home who can help us. And so Luke starts to do his spacer, and Barney's helping him. And Luke's like, no, no, that's not how I'm supposed to do it. Because he had heard 3 different ways of how he was supposed to use his inhaler. And so Barney was able to sit with him and talk with him and use words that he could understand and help him understand why I'm telling you to do this differently than what you heard from 3 people, right? And it wasn't necessarily they all told him wrong information, but it just didn't all match. And so Barney was really able to help clear that up for him so that then he could participate in his care. He's not doing it all by himself. I mean, clearly we're there helping him, but just using words that he could understand so that it becomes meaningful for him. All right, participation. It's the 3rd principle. So this is where patients and families are encouraged and supported. Hear those words because that's very different than allow. We're encouraging and supporting them to participate in care and in decision making at the level they choose. So how do they want to be involved? Are you communicating that we want them to participate? Right? So think about ways that you're actively encouraging them to participate. So some folks are going to choose to be really involved, some are going to choose not to. One's not right and one's not wrong. It just means we have to meet them where they are, right? It's this idea of partnership, where we come in together with them. So my friend Anna is a self-described control freak. When her baby, so she came from the corporate world, when her baby landed in the neonatal ICU, she was completely out of her element. Right, so she came from this corporate world. She was very used to reading her reports every day. She ran numbers all day long. That's what she did. She's always looking at reports, always wanting to know about these numbers. That's what's telling her in her work if they're on the right track or if they're not. So she lands in the ICU with this baby who has Down syndrome and is going for heart surgery and soon. And so she finds herself completely out of control. And she's funny to talk about it now because she'll say, I mean, I did things I would never do. Now, she said, but gosh, I was just so completely out of my element and completely out of control. I was grasping for straws and grasping for anything that could give me some sense of control. And so 2 things for her. One was she always asked for the labs. She wanted the report out, or the printout of her lab reports for her baby. So she didn't necessarily know what it meant when she was reading about the white cells and looking at bands and neutrophils and all this stuff. But she could follow the greater than and less than sign, and she was following normal. And were we in range or out of range? And so, her caregivers could have been really frustrated with her. I'm like, oh God, that lady shouldn't even know about those reports. We're having to give them. She doesn't know what she's looking at. There could have been a lot of that, but instead she was encouraged and supported in that. That's what was helping her cope. And so they helped her with that and talked her through that and helped her know, when we're worried about something and when we're not. It's okay to be a little bit out of the normal range, but we're not going to go this far. This is when we get worried. But meeting her where she is, that's what it's all about, meeting people where they are. The other thing that happened for her is she was moving from the NICU, and after surgery they would go into the pediatric ICU. And so she talks about the respiratory therapist who was working with her in the NICU and said, oh, you're going over to the PICU? Have you been over there? Why don't we go? Do you want to go see? And so grabbed her right then, and they went over and they took a tour of the PICU. And she's 13 years later, you guys. 13 years later, that's what she still talks about. And she says, you just don't know what that did for me. It just helped me be more comfortable. I felt a sense of control knowing where I was going. He didn't have to do that. It wasn't part of his job description, but that was being present in the moment and thinking about, anticipating her needs, figuring out what she might need and stepping in to take care of that. She did that. He did that for her. And that's what she's still talking about 13 years later. What a difference that made. She says it's the simple acts of kindness that make it so much better, because I know they're going to do great clinical work. It's these simple acts of kindness that really make the difference. So the last principle is collaboration, where we're really working together collaboratively with patients and families, right? Where we're making decisions in the clinic and at the bedside, but all the way up to policy and program development, evaluation of our services. The example of that is Jody, right? Jody is one of about 70 patient and family advisors that we have at our hospital. She does all sorts of things at the hospital. That's why we wanted to come together. We wanted to model this collaboration for you. So the challenge is for you guys to go back. Think about your own work areas. Where are areas that you can bring in patient and family advisors? Do you have them at your hospitals? If not, then feel free to reach out to me. I'll help you know how to start that program. But if you do have them, how do you incorporate them into your work? What quality improvement projects do you have? That's a scary thing, and sometimes we don't want to go there and we don't understand where patients and families can fit in. They have so much to offer in ways that we have no idea about. They will find their way to fit in. My advice is to get them involved in your projects, because it enriches the project. It comes out so much better than if it's just us. They're a missing team member at the table. So really, you've heard me say it 2 or 3 times today. I said at the beginning that this is about doing with, not just 2 and 4. So it's not really a you and a me. The sweet spot is when we're at the us part. It's really being intentional about communicating this partnership, about working together. All right, enough of that lecturing. You ready to get going again? We got another activity.
Yeah.
Ready? Okay.
All right, turn your paper over if you still have it out. If not, pull that little blank piece of paper back out. Let's turn it over to the blank side. This activity we're going to call Simple Pleasures. So what I'd like for you to do on the back side of your index card is number 1 through 10 down the side, whichever way you want to, but 1 through 10. And what you're going to do for the next couple minutes is write down 10 things that are your simple pleasures throughout the day, the things that you just don't want to go through a day without. And there's some examples on the screen of things that are important to some people, but think about the things like through the course of your day, whether it's that cup of coffee in the morning, the book, the quiet time to read your book before you go to bed, whatever it is, think about that your 10 simple pleasures, things that you just don't want to do without on any given day. Is it hard to think of 10? Some of you are really deep in thought. It's okay if you don't get 10, but see if you can. Okay, we'll take one more minute. Okay, if your list is complete or close to it, I want you to turn to someone around you and trade cards with them, or pass them around like in a circle if there's several of you together. You don't have to talk about them, but when you get someone else's card, I want you just to randomly mark off 3 things. Doesn't matter what they are, no particular order, just randomly mark off 3 things and then give it back. Yes, you're
someone else's card, and you need to mark off 3 of their simple pleasures. Yeah.
Okay, after you've marked off someone else's 3 of their simple pleasures, give it back and take a look at your own card. Kind of process what was taken away from you. How's that feel? You guys all right? What kind of things did you lose in that process?
Sleep.
Sleep! Oh, that's terrible.
Taking a shower.
Oh no, somebody's not getting a shower. Okay, now trade cards with someone different. Mark off 3 more of that person's simple pleasures.
You should be able to get your card back because the name will be on the back. So don't worry, even if you have to pass a couple of times to get them to get different ones. It's good.
Okay, now pass the card back to its original owner. I've heard of several comments like, that's mean, that's cruel. You guys all right? Okay, so now take a minute, look at your card. If you have anything left on your card, somebody tell me what you were left with. Cleaning. Oh gosh, really? You got to clean. What's that? A good morning kiss. Oh, that's a good thing.
How about that?
If that's the only thing you need. Okay, you got your TV shows, Game of Thrones and Walking Dead. What else were you left with? Sleep?
You were left with sleep.
Oh, you
Good.
got your sleep. Good. Congratulations, you got to keep your husband. I lost my husband in this activity once, yeah. It's bad, I know. Right. So how did that feel, like lose? I mean, of course this is a game, but how did it feel like losing the things, like identifying the things that are important to you and losing them? How did it feel taking away someone else's things, knowing that they love those things? That's no fun, is it?
It's just not nice. That's what we're hearing. It's just not nice.
Well, I want to tell you guys a little story. I mean, it's a great activity to be thinking about what's important to people and things that you would never know, really. Like, the good morning kiss is lovely, but I wouldn't necessarily know that about you, that's really important to you, right? So I'm going to tell you a little story about a good day that I had. After many, many days of living without my simple pleasures. So for me, my simple pleasures would have been tucking my kids in at night, having a meal with my family, getting my kids off to school, talking on the phone with my mom, that cup of coffee a certain way. Like you can get coffee when you're in the hospital, but it's not the same. You know, I like my special kind of creamer. And so we had spent, this is my youngest daughter, Kate, on the screen, and she's the one I was referring to a while ago. And so we had spent, after we were finally admitted to the hospital, she spent quite a few weeks on a ventilator in the pediatric ICU, and ultimately diagnosed with a rare autoimmune disease. So this is kind of a picture of what we were dealing with in the process. And so my world was turned upside down. I had 4 kids at home. Like I'd mentioned earlier, it had only been a few years since we had buried our son. And so we were on this roller coaster, not knowing if she would live to see the next day. I mean, we had teams of specialists coming every day trying to figure out what was wrong with her. And so I didn't leave the hospital. I may have left once or twice to go home and kind of tag team and get a shower at home, but I was taking my showers at the hospital, I was sleeping at the hospital. I wasn't drinking my coffee, that's for sure. I didn't talk to my other older children often during that time. We talked on the phone, but we didn't bring them up to see Kate this way. And then Father's Day. Father's Day was our good day. It was 2010. And she woke up and she was able to be extubated successfully. And so that's where we were after a couple of months of this mysterious disease. And that was a rough time. It really was. We were journaling every day, and sometimes I look back and think, wow, that was a roller coaster. So we had spent many, many days, weeks of our life being turned upside down. All those things that like haven't been taken away from us, not by anybody's doing, just life happened this way for us. So Kate was awake. You can kind of see in that picture, she still didn't know where she was and who she was and what was happening. And she was just under 2 years old at that point. And so we finally brought all the kids up to see her. She was awake, and so we decided they could come and visit her, and they had missed her so much. And so we brought the 4 other kids in. And that was good for us still, but it was still a little uneasy. And our respiratory therapist, bless his sweet heart, he's not here today, and I really was hoping to see him. He just saw an opportunity to bring a smile to our faces. And so Cameron, who was 8 at the time, the respiratory therapist said, "You want to try it?" And so he put that vest on my son, and it shook him, and he talked and he sang. And we laughed for the first time in 2 months. The whole family together, we laughed. And that was such a special touch for us. And we have memories, and we talk about that, and we laugh about that day. And I wish I had the video. The video clip was just not, it couldn't be seen, and we tried. But to hear Cameron's voice and to hear everybody laughing, and Kate still didn't quite know what was going on, but that changed the atmosphere for us in that hospital room. And we still had a long, long road to recovery with her. And I'm happy to say that she's fine and well in the 3rd grade and doing really great. And that's my sweet family right there. And so I just want to say, as a family member, as a patient myself, I've been able to live through the hard times and grow through those. But those little, like Julie said, those extra things that it was not part of his job to entertain the family or to engage the other kids, but he did. And that made our good day. And that was the first good day we'd had in a long time. And we have fond memories of that day. And so as a mom and as a patient, I want to tell you guys thank you for everything that you do. I just am your biggest fans for going in every day and taking care of folks and doing things that I don't understand what you're doing, and I trust that you do. But I just love that you do that with a special touch, and it means so much to us. And I want to thank you. Thank you for going in every day and taking care of the patients that you do. And I have children that I wouldn't have had otherwise if it hadn't been for healthcare providers like yourselves, you know, that just came in every day and took care of us. So I really appreciate it. Thank you for all that you do every day.
So I love Jody's story, and I love that example of Karen being able to wear the vest. So it is so much about that therapist seizing the moment. There was an opportunity to bring some comfort and joy to that family. You have to be looking for those moments. You have to be aware of that, right, and be able to seize that. But the other thing that happened in that event, right, was education. We had respect for that whole family being together in the room. We were respecting them as a family. We were sharing information with him, with actually all of the family, right? So they got to talk about, what does that vest do? This is why Kate wears it, and how many times she wears it, and this is what that does to her. It feels funny for you, but here's what it does for Kate. Right, it's education, not just for Jody and Mark as parents, but for these siblings who are struggling to understand what's happening with their baby sister, right? And it created this opportunity for everybody to participate, for that whole family to be able to be together and be right in that moment and understand what's happening with their loved one. There's so much richness in that, and I just appreciate that example so much. I always love it when she tells it. So just in closing, you guys, what's the secret sauce to creating a positive patient-family experience? You probably picked up on it already, but it's really about being intentional. It's being intentional with the way we communicate, being sure we're giving complete information in ways that they can understand. It's being intentional about being present in the room. It's so easy to be preoccupied. We have so much stuff that we have to do and so many regulations. Be intentional when you're going in. Take a moment and tell yourself, I'm going to be present with this person. It's being intentional about seeing them as the whole person. It's being intentional about working as a team with the other healthcare providers, but also with this patient and family. And it's being intentional about making a difference for someone. What questions or comments do you guys have? All right. Well, thanks again. We appreciate you. So, oh, wait, we have a question. We have a question.
It was just a
or comment.
I just wanted to tie back into now why I was saying about patient satisfaction and experiences, because when you are intentional, in care, then every single time that experience should be satisfying. That's what I was trying to
That's right, yeah.
say, that every patient experience should be satisfying.
That's right, yeah.
Come back to that.
Exactly right. You nailed it. Any other thoughts?
I remember your daughter.
Uh-huh. You remember that belly? Is that what you're saying? That looks familiar?
I remember right
Uh-huh. Thank you guys.
Thanks so
Appreciate
much.
it.
Okay. We're going to wrap up our first day here. Did everyone have a good experience today? Good, great. Okay, first of all, those speaker evaluation forms I've been asking you about to fill out throughout the day. Now is the time to make sure they're complete so that you can get your certificate for your CEUs when we finish up here. We're going to give away 5 door prizes real quick. Those tickets that you were given this morning, pull those out, and Kevin's going to pull, well actually I'll pull the first one out. Okay,
453-736. 453-736. Someone listen for someone to cheer in the other room. Oh, all right, we have a winner. He's going to win a gift card to Chick-fil-A. How much is that for, Kevin? $7. $10. All right, this is going to be for a cup of candy. 453-550. All right, right up there. Next up will be a gift card for $10 to Starbucks. Four, 5, 3, 7, 2, 8. 4, 5, 3, 7, 2, 8. Is anyone checking the other room?
Is there anybody in that room, Sheila? Nikki's gone. She won't remember the number.
For you guys in the other room, 4, 5, 3, 7, 2, 8. We'll move on. This is for another cup of candy. 4, 5, 3, 5, 3, 8. 4, 5, 3, 5, 3, 8.
Going down.
Yeah, we're going down quick. Back to the Starbucks card. $10. 4, 5, 3, 5, 5, 5. 4, 5, 3, 5, 5, 5.
It's mine. I wish.
Okay, cup of candy. 4, 5, 3, 7, 2, 3.
723.
723. All right, we got a winner. We'll go back to the Starbucks card. Oh, what number? 538.
Yep.
That's for the Starbucks card. Okay, we got one left at Chick-fil-A for $10. And before I tell you this, the golf carts will be running until 4:45 if needed to take you back to the parking lot. We'd like to thank our vendors for being present and helping us sponsor this seminar. They're on the back of your brochure. And I'd like to thank you all for attending today. Don't forget, tomorrow starts at 7:30 with registration and breakfast. And the last ticket number is 453571. All right, we're going to keep going till someone wins this. 453746. Four, 5, 3, 5, 3, 9. We have a winner. All right. Everybody have a great evening. We'll see you in the morning. Don't forget to turn in your speaker eval form to get your CEU credits. Thank you. At the tables right outside in the atrium. Oh.
You know, we're supposed to be deleting all those off.
We will at
I took Shane's tomorrow.